let's study something. So we discussed omphalocele, so now we'll talk about a gastroschisis. Gastroschisis and omphalocele often get confused. Omphalocele is through the umbilical cord itself. It's protected by the Wharton's jelly, whereas a gastroschisis is a full thickness abdominal wall defect to the right of the umbilical stump. Another big difference is omphalocele is often associated with genetic defects or other like cardiac defects for the baby, whereas gastroschisis is isolated, so there's not typically any other defects or genetic condition to worry about. Prognosis is excellent for gastroschisis, over 98% survival rate in the United States. And you can typically see the gastroschisis on the 20-week ultrasound, and if you check labs, the maternal alpha-fetoprotein is elevated. Because the gastroschisis is to the right of the umbilical stump, the bowel is not protected by Wharton's jelly like in omphalocele. So the bowel itself can sometimes be stenotic or atretic. It can also have fibrous tissue in it. So the integrity of the bowel may be a little bit worse just because it is free floating and not protected by Wharton's jelly. There were studies to look at whether a C-section was better for delivery for a gastroschisis or a vaginal delivery, and you can do a trial of labor. As long as the baby is tolerating labor, the recommendation is to deliver these babies vaginally. Once the baby is born, it's important to protect the bowel, so you can put it in a bowel bag, put the baby on its side to kind of decompress or take off any pressure. Baby will need an NG tube to decompress the stomach and then IV for hydration, just because of the large evaporative losses that can happen through the exposed bowel. The goal is to just do a silo initially, so it's basically a bag where the bowel sits in, and then through gravity and pressure on the bag, the bowel will go into the abdomen itself without us having to force it in. If we can do a silo, excellent. When the bowel goes back in, you can actually do a sutureless closure, which you take the umbilical cord and lay it over the defect somehow. I'm not a surgeon, so I can't speak to it, instead of doing a primary closure with sutures. One thing to always remember is anytime you have an intra-abdominal surgery or pathology, you want to have abdominal compartment syndrome in the back of your mind. It is a surgical emergency. You'll see decreased urine output, maybe abdominal distension, respiratory distress, and low blood pressures, but it's something to always kind of have in your mind when you have a baby with a gastroschisis or omphalocele that is going through the process of getting reduced back into the abdomen.